Hello friends, it's indeed a great pleasure to talk to you about what has happened in the world of ID as the earth has moved around one more time around the sun. In some ways we have made progress and in some ways we find ourselves in the same place where we were. To find out which are the most important papers in 2021, I did a Google search, and to tell you the truth, I was as confused as some of our patients are when they do a Google search. So there were just too many papers there, and therefore I was thoroughly confused. So I asked myself a bunch of questions and then trying to review the paper which answers that question the best and what is its applicability in our practice. So how do the new diagnostics for bloodstream infections help? So sepsis mortality we know is very high, and of this about a third is due to bloodstream infections. Impairing antibiotics should be appropriate, but that is based on the ID of the organism and its susceptibility. Now these are not available in a suitable time frame, and so there is a big unmet clinical need. There's a new FDA cleared multiplex PCR BCID panel which is to be used on a positive culture. So these researchers looked at how that would help in fashioning the empiric antimicrobial therapy in the critically ill septic patient. So there were 78 cultures and the results, the culture was positive in about 16 to 17 hours. And BCID1, which was available to the researchers, that gave an earlier report than the final report by conventional methods by as much as 2 days. Antibiotics were adjusted in about a third of these patients, of which most were escalated, some were de-escalated, and about 14% were multi-drug resistant, needing more infection control measures than were being already used. So what is the applicability in our practice? We have with us, fortunately, BCID2 panel, which has certain additional organisms, and they are important, such as Stenotrophomonas and Candida auris, as well as a lot of drug-resistant mechanisms. Additionally, friends, we also need Burkholderia, we also need Elizabeth Kingia, perhaps we also need Burkholderia pseudomallei and S. typhi for community-related problems. So the cost versus benefit, now remember this test is fairly expensive. So that would depend on what's the prevalence of unsuspected, highly resistant organisms, what's the local empiric practice, what's the true turnaround time of using the test in a hospital setting, and whether a proper action was taken after the report came up. For example, if the susceptibility was showing that you can de-escalate, was it done? What's the cost of antibiotics, the cost of length of stay in the ICU, as well as the true collateral damage. So all these factors will be needed to be taken into consideration when we decide whether this test is going to be really helpful in practice or not. I'll give you this example. This was a liver transplant recipient for chronic liver disease. He had a stricture, cholangitis, and bacteremia. And what we did was an off-label use of this test. So this was done on bile culture, not just on the blood culture. So the question is, what would have happened if we didn't have the PCR panel, and what actually happened because we did have it? So inappropriately broad or inadequate or toxic empiric therapy could be avoided. For example, in this case, we would have liked to cover for gram-negative bacteria. Now, whether they should be carbapenem susceptible or carbapenem resistant, and if they are carbapenem resistant, it is what is the mechanism? Is it NDM or is it OXA48 like? All these questions could be answered. Was there a need to cover enterococci or anaerobes or even some candida species? Now remember that these are often empirically covered in biliary sepsis. So this test told us that there was no other organism but Klebsiella pneumoniae, and it was producing OXA48 like enzymes as well as CTXN. So in this particular patient, we could treat this patient with ceftazidime-avibactam. We did not actually require even ceftazidime-avibactam plus aztreonam. Remember that this particular combination can have liver toxicity, not really good for this particular patient. The next question was, is combo better than monotherapy for MRSA bacteremia? Now we know that Staph aureus bacteremia is quite a big problem. High mortality occurs. We certainly need better therapy for this. And there are problems with the standard therapies such as vancomycin, teicoplanin, daptomycin, linezolid, and so on. And combinations with other drugs also have some issues. So Fosfomycin is, we know, it's a good drug for Staph aureus, and it may have synergy with daptomycin, as has been seen in certain rabbit models. And there are definitely some mechanisms by which it might actually synergize with other agents. So these researchers looked at daptomycin plus fosfomycin versus daptomycin alone for MRSA bacteremia as well as endocarditis. And what were their findings? That the combination did have a lower rate of microbiologic failure and lower complicated bacteremia had resulted. But at the end of it all, it did not benefit mortality. The treatment success at the end of treatment was more or less the same in both the groups. In fact, there were more adverse drug reactions, obviously, with the combination, which led to drug discontinuation in a fairly good number of patients. So what's its applicability? Now the debate continues between vancomycin and daptomycin, each one of them either alone or with other agents. Now some benefit of adding fosfomycin to daptomycin was seen in this study. However, that seems to be offset by the adverse drug reactions. So are there any patients where we might consider? Yes, we might consider the combo if the MIC of the organism is relatively high in those who have severe disease and in relatively young patients who might not get that much of a problem with safety issues. So let's look at this example. This is a patient on maintenance dialysis who had a septic arthritis of the hip. He had MRSA bacteremia. As you can see, there is a large vegetation there. So he's also got endocarditis. And if you look at the susceptibility here, the vancomycin MIC is 2, which is still susceptible, but definitely it is in the higher range, more than 1 or 1.5. So can we use fosfomycin in this particular patient as an additional drug to daptomycin? I think probably yes. So we need to check whether it is susceptible by doing a fosfomycin E-test. We know that fosfomycin has a good penetration both in joints as well as in vegetations. But we need to consider sodium overload, hypokalemia, arrhythmias, and perhaps use it only for the initial 1 week when the benefit may be the maximum and adverse drug reactions are likely to be the least. What might be the reasons why carbapenems are better than BL-BLI even when pip/tazo is reported as susceptible for ESBL? And the question is, are they really better, and should we always be using the carbapenems in preference to, say, pip/tazo? So the Merino conclusions were clear. They did not support pip/tazo at all for bloodstream infections due to ESBL producing Enterobacterialis, and therefore carbapenems are considered as gold standard. However, avoidance of carbapenems can be seen as a key stewardship practice. So what might be the reasons why, despite pip/tazo being susceptible, how did it not fare well as compared to the carbapenems? So that was the question, and this is the study which answers that question. So rigorous testing of the MIC and resistance genes was done by whole genome sequencing, and that revealed the reasons why there was a difference despite all the organisms remaining susceptible to pip/tazo. So what they found in these 320 isolates from a large number of patients was that there were significant issues of performing pip/tazo resistance testing. And those isolates whose pip/tazo MICs were greater than 16 were actually co-harboring ESBL as well as OXA1. So there were several mechanisms of resistance, and therefore these patients who were harboring these strains had an excess mortality of 14%. So this perhaps is the reason why carbapenems appear to be much more superior to the BL-BLI. And in this context, the UCAST resistance breakpoint of greater than 16 seems to be more appropriate than the CLSI resistance breakpoint of 64. So in this range between 16 and 64, which UCAST calls as resistant, but CLSI calls it as non-susceptible, probably the carbapenems will have a definite edge over the piperacillin tazobacter. Now, what's the applicability of this analysis on our practice? So the question is, will pip/tazo remain equally effective as meropenem if the patient is not exactly like that in the Merino trial? So those patients who have UTI but without a bloodstream infection, or if we use a higher dose and a prolonged infusion of pip/tazo, if there is a very good source control possible, maybe with surgery, and in those patients who have a low mortality risk, In these situations, will carbapenems retain their edge over the piptazo? That seems to be a question. Now, whether other BLBLIs, and we have a large number of them today, would they be more or perhaps less effective than piperacillin tazobactam? And each one of them will have some plus or minus points against them. Now, what was tested was meropenem. What about other carbapenems? Will they be equally effective or less effective? And even if piperacillin tazobactam is not used as initial therapy, can it be used for de-escalation in the interest of stewardship? And what about, and in the study, they found that C. diff and other superinfection did not increase in the same patient during the trial. But the larger question is whether there's going to be an overall ecological impact in both the hospital and other environmental flora. Now, that question again remains somewhat unanswered. And therefore, perhaps the BLBLI versus the carbapenem debate continues into this year, into 2022. And it really depends on what is your viewpoint, what is the type of patient, and how we are going to use the drug for which indication, and so on. The next question I had asked was, what is the ceftazidime-avibactam plus aztreonam better than a polymyxin? Now, there is a growing realization among all of us that polymyxins are not so efficacious. And there is a study called CRACKLE, which showed that ceftazidime-avibactam was better for KPC producing enterobacteriaceae. So the optimal treatment for bloodstream infections due to MBL producing enterobacterialis is not yet defined. Now, the efficacy of ceftazidime-avibactam plus aztreonam has been found in vitro, and it's commonly used. All of us have used it commonly in India, but there are no clinical studies which have been reported properly. So the hypothesis may be that this combination may have better efficacy than all other active antibiotics. And with this in mind, researchers did this study, which was checking whether efficacy of ceftazidime-avibactam plus aztreonam in patients with BSI by MBL producing enterobacterialis. What happens? So in this, they found that the groups were well balanced, although it was not a properly randomized study. So they used very sophisticated things such as propensity score and matched analysis, as well as a variable ID prescriber was included in order to get over the problems of not having a proper randomization. The results were as expected, that Cas-IV-aztreonam had a significantly lower 30-day mortality, as well as lower incidence of drug-related acute kidney injury. Again, the comparative drugs were other active antibiotics. Most of them were colistin-based regimens, and that led to the conclusion that this might be a better choice, both in terms of a better result as well as lesser toxicity. So this does provide support for the use of ceftazidime-avibactam plus aztreonam for serious MBL-producing infections. Now, this might be especially true for CNS, pulmonary, and osteoarticular sites, reminding you that colistin and polymyxin don't penetrate very well into these three sites. However, there are some concerns of hepatotoxicity, interstitial nephritis, and cost. Also, there are some unanswered questions like what might be the optimal in vitro testing methods, what might be the best dosing regimens, how can we use prolonged infusions, what sort of adjustment do we do for renal dysfunction and replacement. What has been recommended is very, very low dose when the creatinine clearance is around 10 or 15, but that might not be enough, and there are some papers which show that too. Now, will the results apply equally well if it is not just MBL, but MBL plus OXA48-like? Now, we know that lots of Klebsiella in our country produce both these carbapenemases. In this situation, will the ceftazidime-avibactam plus aztreonam fare very well? That is a question, and in practice, though we see it, it has not been answered by this particular trial. Now, how long do you think that this combination is going to work? Now, there is already a problem here. Mechanisms like insertions in the penicillin binding protein 3 of some of the E. coli can compromise the efficacy of aztreonam as well as avibactam. So friends, there might be a problem which may be on the horizon. Still, I think it's a very good drug to use for enterobacterialis. However, we may still have to use the polymyxins for Acinetobacter and for some of the Pseudomonas, because you know that they do produce different types of oxa enzymes as well as other problems, and that's why ceftazidime, avibactam, and aztreonam may not be good drugs for carbapenem resistant Acinetobacter baumannii. Now, what is the antimicrobial stewardship experience in the real world? Now, a lot of that has been said, and we have lots of papers from abroad, but I really turned to one of the papers from Mumbai, from Kokilaben Hospital. So we know that the stewardship program leads to reductions in broad spectrum antimicrobial use, in the incidence of new infections, in colonization by resistant organisms, and so on, and all this without increasing mortality. So the traditional way to do this was to restrict the use, do chart reviews, and make recommendations, and often that is led by a pharmacist, but that leads to low acceptance rate among the various clinicians. Really speaking, it's a problem of delivering advice to those who have not even requested it. And therefore, these researchers looked at what happened when they did an implementation and what was the outcome when they used feedback based on antimicrobial stewardship program at the hospital in Mumbai. So it was a prospective audit and feedback, and it was sought to be made more effective and accepted. Now, justification form was used which was reviewed by the Antimicrobial Stewardship Committee. Eligible prescriptions were judged as justified or unjustified based on the patient's clinical profile, previous antimicrobial history, course, results of investigations, cultures, matched with the guidelines, and then communicated to the treating team. Now, there were a large number of restricted antimicrobials which were used in about 1,000 and more patients, which were available for review. Now, it was found that 1.4% of the admitted patients were prescribed restricted antimicrobials, and the total days of therapy was this much. Now, it was judged that 12.5% of these were unjustified, and recommendations for de-escalation were accepted in close to 90%. So that was something which is very interesting. However, there are questions like designation of some of these antibiotics as restricted is somewhat arbitrary, and it's really based on many clinical factors. And sometimes it is difficult to adjudicate whether the use of these antimicrobials was justified or unjustified. Besides the more difficult question, use of multiple antibiotics, what dose was used, whether they did PK/PD optimization, what was the duration, monitoring, and collateral damage are even more important, but even more difficult to study. On the downside, you need a continuous availability of all the team members is needed. The success depends on the team's credibility. Now, this was driven by a particular infectious disease physician who has a high credibility, and therefore many people listen to what the team had to say. It is certainly labor intensive. It needs commitment by the team, top management, as well as perhaps a full-time specialist system in the hospital might be helpful. So this I might call as a handshake stewardship. It might be more effective and sustainable, leading to long-term relations with the primary units and the antimicrobial susceptibility stewardship team. Let's take an example of this. Now, this was a young patient who presented with respiratory infection. As you can see, there is this large consolidation as well as some other ground glass opacities. The COVID test was negative. The patient was prescribed piptazo as well as azithromycin as well as fluvir by the treating physician. Now, this was the LRTI panel multiplex PCR, and what was found was 3 different gram-negative organisms, Klebsiella, Pseudomonas, and Serratia was found. Then there was a CTXM as well as NDM genes were detected. That was the nucleic acid material was detected. And a coronavirus, which is an endemic coronavirus, was detected. You might note that there were no atypical pathogens, pneumonia pathogens such as Chlamydia, Legionella, Mycoplasma, and there was no influenza A. So looking at all this, the physician had started piptazo, azithromycin, as well as fluvir, and looking at these NDM and CTXM, he probably wanted to add ceftazidime, avibactam, and aztreonam. But thankfully, he had written only if I agree. So let's analyze this case. Now, this endemic coronavirus is never a colonizer. So really speaking, that is the true pathogen here. And it is described that unilateral consolidations can occur in this illness. Now, this patient was a young patient. She had no comorbidities at all. She had no prior healthcare exposure, no antibiotics, and her WBC was normal. So can you imagine 3 different gram-negative bugs actually producing pneumonia in her? So obviously not. So these are only colonizing nucleic acid coming up from colonizing flora. Similarly, there were no atypical pathogens detected. There was no influenza A. And actually, we stopped each and every antibiotic and antiviral in this patient, and the patient made a very good recovery. So this is something called as a handshake stewardship. So if you discuss each and every aspect of this with the primary team, with the treating physician, I'm sure they would accept when you say that you should not be treating this particular patient with anything at all. Now, do some of the new diagnostics help for COVID-19 associated infections? So we have a perception that there is a predisposition to secondary infections, and patients have been used to the tune of 70 to 100% have been treated empirically, whereas the infection has been found only in a very small percentage. Now we know that these non-culture based methods like the one I showed you before has certainly high sensitivity and specificity, and it may help us in judicious therapeutic decisions and promote stewardship. So this is what they used for COVID-19 patients and came up with this fact. So they found that the yield of organisms was higher by this test as compared by the culture, and the turnaround time was definitely shorter. But they found that this actually could produce changes in the early treatment, mainly discontinuation or avoidance of antibiotics, as we saw in this particular patient, and no change in the remainder. So what's the applicability? I did show you that applicability in that example. So we need a good clinical correlation. We also need some off-panel organisms. We have to interpret the bin value, because remember, these are not actually colony forming units, but bin value. We also must understand what's the genotypic resistance epidemiology here, and so on. And at the same time, we must have a cost versus benefit analysis. My final question was about infection control for COVID-19 in the hospital. So little is known about whether clusters would occur in healthcare settings, and lots of failures of the PPE as well as lapses in infection control could be involved. And really, they may be more consequential, more common than we think, especially in the view of the recent variants of concern which have high transmissibility. So in this particular study, they used epidemiological investigation as well as whole genome sequencing to track how the patient was able to spread infection in the healthcare setting. So the index case was a patient who had 2 negative tests but tested positive after 4 days and went on to infect a cluster of 38 staff and 14 patients. And what they found was the usuals, that high viral loads, cough, dyspnea, nebulization, no eye protection, sharing of rooms, positive pressure room, no distancing, especially during staff breaks, and interaction with infected staff. So these were the reasons why the cluster occurred when they actually missed detecting a particular patient. So the applicability is that there are problems, and all of us know that the sensitivity of testing is imperfect. And there might be varying infectiousness of the patient, which possibly depends on the stage of the illness. There might be aerosol transmission at short range. There can certainly be lapses in the use of PPEs, lack of distancing during staff breaks. Now, all of these can really add up in the healthcare setting in order to produce a cluster. So I close, friends, by saying that many studies have been published. Some of them have been real practice changers. But let me tell you, science advances by a series of small steps, rarely by a single giant stride. Now, we must remember here that practice can rapidly become out of date without the best current evidence. Therefore, we need to keep searching that. But external evidence has to be carefully assessed for applicability in the care of an individual patient. And really that when you do that, it often generates questions which help direct further future studies. So my mantra is we have to search answers even while the patient is being managed. And sometimes I would say this, that bedside to library and back again to the bedside can really be helpful in the management of the individual patient. I'll end by showing you this plaque which is there at the door of the Mayo Clinic library, which says enter in to learn and go forth to serve, which I think sums up exactly how we should be using the literature in order to solve our problems in front of us. And with that, I will stop my screen share and thank you for your attention.